Good morning, ladies and gentlemen. I, Nicholas Sade, will be presenting a PowerPoint presentation on dyslipidemia, submitted in partial fulfillment of the requirements for EHR 403, Pathophysiology of Chronic Conditions for Charles Sturt University. Peter has been referred to the Charles Sturt Exercise Clinic for lifestyle interventions. He is a 52-year-old bank manager and recently diagnosed with dyslipidemia. Other than his new diagnosis, Peter is asymptomatic. Dyslipidemia refers to abnormal concentrations of serolipoproteins. The term lipoprotein refers to lipids, phospholipids, cholesterol, and triglycerides bound to carrier proteins. These carrier molecules assist in transporting lipid-based molecules through the water-based environment of the blood. The density of these structures is determined by the ratio of protein to lipid, and this relates to whether the structure is good or bad. When Peter's blood lipid data is compared to the American Heart Association third report of the National Cholesterol Education Program 2002 indicates Peter's total cholesterol of 223 mg per deciliter is considered borderline high. His low-density lipoprotein of 185 mg per deciliter is high, and triglycerides ATP3 of 123 mg per deciliter is normal. Nonetheless, this strong data represents his high levels of total cholesterol and low-density lipoprotein in the blood. Therefore, Peter is diagnosed with hypercholesterolemia. Poor diet can increase an individual's total cholesterol, low-density lipoprotein, and decrease high-density lipoprotein. Ingestion of excess cholesterol intake, saturated and transaturated fat, and cholesterol can affect the removal of low-density lipoprotein. Therefore, preventing the removal of low-density lipoprotein from the bloodstream. This has been reported in diets that are high in saturated fats and intakes of high levels of calorie intake increases cholesterol synthesis, therefore preventing low-density lipoprotein activity. Diets that are high in trans-saturated fat elevate LDL to HDL ratio and increase total cholesterol, also increase inflammation and also as well as increase the risk of coronary heart disease. Secondary risk factors include diabetes and hypothyroidism. Studies in genetic disorders have reported a link between low-density lipoprotein and evidence towards atherogenic lipoprotein, where low-density lipoprotein is elevated above the normal range without the risk factors of chronic heart disease. The genetic disorders are heterozygous and homozygous forms of familial hypercholesterolemia. Heterozygous familial hypercholesterolemia is inherited by an autosomal dominant disorder. Because of a defect in the mutation of the gene low-density lipoprotein receptor, resulting in above normal level of total cholesterol and low-density lipoprotein, with vast number of mutations disturbing the function of low-density lipoprotein receptors have been studied. Homozygous familial hypercholesterolemia affects 1 every 500 people. Is usually detectable after birth with levels of total cholesterol reaching 300 to 500 mg per deciliter. This normally happens to males by the time they reach the ages of 40 to 50 years. Peter should attend an exercise physiologist clinic. The reason for this is because exercise physiologists are important for Peter, because they specialize in the delivery of clinical exercise intervention for individuals at high risk of developing existing or complex medical conditions and injuries. The interventions are delivered through exercise and health education, lifestyle modification programs focusing strongly on behavioral change. Physical therapists deal with only acute injuries, usually musculoskeletal injuries. Exercise physiologists provide services in individuals and group-based lifestyle counseling support for self-management. As an exercise physiologist, I will provide Peter with ongoing monitoring of his behavior changes with the concept of promoting his confidence to manage his lifestyle independently. The prescription of exercise for Peter will be specific, well researched using only high evidence material in order to ensure the activities are safe, effective, and as well as likely to be continued long term, where he will have the option of a home-based prescription or attend the Charles Sturt Exercise Clinic. As an exercise physiologist, I understand the barriers that may prevent Peter from attending the clinic or performing the program at home. For example, lack of time. We would work around these barriers to find a time suitable for Peter to attend or perform the home program. The mode of action of statins. Statins affect blood cholesterol by inhibiting hepatic cholesterol synthesis, which results in increased expression of the low-density lipoprotein receptor gene. The greater number of low-density lipoprotein receptors on the surface of the hepatocytes results in an increased removal of low-density lipoprotein from the blood, thereby lowering low-density lipoprotein levels. Statins act by inhibition of HMG coenzyme A reductase, taking its place in the HMG coenzyme A pathway because of the identical molecular level. This blocks the access of this substrate to the active site, mevalonate, a critical intermediate in the cholesterol pathway. It was reported by Isfahn and Dysenhoff 2001, Thompson and Crew 2003. Increase in low-density lipoprotein. In response to reduced liver cholesterol levels, hepatocytes in the liver synthesize more low-density lipoprotein receptors to draw cholesterol out of the circulation. In response to the reduced free cholesterol content within hepatocytes, increase in concentration and activity of membrane-bound sterol regulatory element binding protein that is able to bind to the peroxidase promoter, increases the production of low-density lipoprotein receptor gene, enhancing the transcription and increasing the synthesis of low-density lipoprotein receptors. Was reported by Horton and Crew 2007, and as well as being beneficial in the increase of high-density lipoprotein levels. Was reported by Deacon and Crew 2003. Prevention of coronary heart disease with pravastatin in men with hypercholesterolemia by Shepherd and Crew, 1995. Examine the effect of statins on cardiovascular events in individuals with hypercholesterolemia and with no history of myocardial infarction in a double-blind study. This trial specifically enrolled 6,595 men between the ages of 45 to 65 years of age with moderate hypercholesterolemia, 272 plus minus 23 milligrams per deciliter. The follow-up period was 4.9 years. Figure 1 represents the effects of pravastatin therapy on plasma low-density lipoprotein cholesterol levels. Pravastatin therapy decreased plasma cholesterol levels by 20%, low-density lipoprotein by 26%, triglycerides were decreased by 12%, and high-density lipoprotein increased by 5%. There was no significant changes in the placebo group. Shepherd and Crew findings conclude that pravastatin therapy significantly decreased the risk of myocardial infarction and death from cardiovascular causes in their male subjects with moderate hypercholesterolemia. The primary prevention of acute coronary events with lovastatin in men and women with average cholesterol levels was studied by Down and Crew. This study was a randomized, double-blind, placebo-controlled trial with a total of 5,608 men and 997 women with an average total cholesterol 221 milligrams per deciliter and a low-density lipoprotein of 150 milligrams per deciliter. The control group were given lovastatin 20 to 40 milligrams daily, and the placebo group received a low cholesterol diet. The results reported lovastatin had a significant effect on changes in lipid levels from day 1 to post-treatment, as assessed at 1 year. Low-density lipoprotein cholesterol levels were reduced by 25%, total cholesterol levels were reduced by 18%, triglycerides were reduced by 15%, and high-density lipoprotein were increased by 6%. This concludes that statin treatment reduces the risk for acute major coronary event in men and women with average levels of cholesterol and triglycerides. These findings also suggest the impact of high-density lipoprotein may be more protective for the development of atherosclerosis, which was backed up in another study by Toth 2004. Quantifying effect of statins on low-density lipoprotein cholesterol, ischemic heart disease, and stroke. Systematic review and meta-analysis by Law and Rudnicka, 2003. The objectives were to determine how much statin can reduce serum concentrations on low-density lipoprotein. 164 short-term randomized placebo-controlled trials of statins on studies of subjects with elevated levels of low-density lipoprotein, ischemic heart disease, and stroke. Table 2 shows that in the first year, the reduction was 11%, in the second year 24%. In the first and second years combined, there was a difference of 13%. The reduction in the third, fourth, and fifth years combined was 33%, and the sixth and subsequent years was 36%. The reduction in low-density lipoprotein cholesterol and duration of statin treatment significantly reduced the risk for fatal and non-fatal ischemic heart disease events. If Peter is unsuccessful in managing his increased levels of low-density lipoprotein long-term, secondary health conditions that Peter may be at risk of developing include ischemic heart disease, atherosclerosis, stroke, and high blood pressure. This is as a result of increased low-density lipoproteins freely circulating in the bloodstream provides building blocks for atherosclerotic plaque development within the blood vessel wall, deep within the endothelial walls that line the artery walls. Once an atherosclerotic pathway is developed, the blood vessels become twisted and tortured, progressively impeding on flow of blood by stenosis or complete occlusion. Hypertension, or high blood pressure, represents the pressure of the blood against the blood vessel wall. This pressure can cause damage to the endothelial cells, leading to micro tears. Injured endothelial cells become inflamed and cannot make normal amounts of antithrombic and vasodilating substances. When the endothelium is injured, it loses the ability to prevent clotting and to vasodilate. This results in platelets aggregating when thermoboxine A2 increases, and the release of serotonin and endothelin combines to cause vasoconstriction. This leads to a decrease in blood flow and ultimately ischemia. And at the same time, activation of the sympathetic nervous system allows for vasoconstriction of noradrenaline to be released by converting angiotensin I to angiotensin II through ACE inhibitor. Therefore, vasoconstriction occurs and increased clotting. Boyle 2005, Swacker and Crew 2001 stated that inflamed endothelial cells bind towards macrophages, releasing numerous inflammatory cytokines and enzymes that further injure the vessel wall. The inflammatory process of oxidation on low-density lipoprotein becomes engulfed through macrophages, further penetrating the intima of the vessel. These vulnerable plaques are at risk of plaque ruptures, ulcerations, or erosion, usually where the fibrous cap is at its thinnest and where the mechanical stress is at its highest. This was reported by Libby and Crew 2002.